Kia ora koutou, no mai haere mai to tonight's Goodfellow webinar. My name is Katie McCulloch. I'm a nurse practitioner working in Tamaki Makaurau. Tonight's webinar is part of the Te Tiri Whakāro Sharing Knowledge series. It's commissioned by Te Whatu Ora to support primary care. So this webinar tonight will have a session on Doxy-PEP, an overview of the guidelines and their implementation, and a session on Te Whata Kura, a new national antibiotic guideline. And we have our standing segment of clinical updates covered by Dr Sue Tutty. Our first session tonight will be on Doxy-PEP, with Dr. Jeannie Oliphant. Jeannie is a sexual health physician and the clinical director of Auckland Sexual Health Regional Services. She completed specialist qualifications in sexual health in 2013, and prior to this, she worked as a GP in Whakatane. Jeannie has also worked for the Centre for Youth Health in Counties Manukau and at the Auckland Adult Sexual Assault Service. Thank you so much for joining us tonight, Jeannie.
Kia ora koutou. Lovely to be here. So really excited to talk to you about Doxy-PEP tonight because I think it's a good news story, and I think in health at the moment we really need that. So I'm just going to start with a hypothetical case, and this is a 26-year-old young man called Taumata who comes to see you in your office, and he's presenting with a purulent urethral discharge. So you diagnose and test and treat him for urethritis on the day. And then as you're looking back through his notes, you notice that he was diagnosed with rectal chlamydia back in January of this year, and he has a past history of syphilis in 2022. And his results come back positive for gonorrhea. But as you're musing, you think, wouldn't it be amazing if you could have some kind of tool that would stop that revolving presentation of STIs for this young man? And in fact, that's exactly what we have got now. So quite exciting when we get something new and it's a novel intervention. So there's been 3 RCTs overseas that have looked at the efficacy of Doxy-PEP. So Doxy-PEP is Doxy for doxycycline. PEP is post-exposure prophylaxis. So it's utilizing doxycycline, 200 milligrams taken within 72 hours of condomless sex. So the RCTs overseas have looked at people with a penis, so men who have sex with men and transgender women who have sex with men who are at risk of bacterial STIs. And when they were randomized into 2 groups, the group randomized to take Doxy-PEP showed significant reductions in syphilis and gonorrhea. So it reduces your chance of acquiring those STIs after sex by about 70 to 90%, so quite significant. There wasn't really much evidence of a reduction for gonorrhea, and that's largely due to variable tetracycline resistance in different parts of the world. And in terms of the Aotearoa context, we wouldn't expect Doxy-PEP to be effective against gonorrhea because we have quite high levels of tetracycline resistance here anyway. And why are we so excited about Doxy-PEP? So the big reason here is syphilis. As you're probably all well aware, we have a syphilis epidemic in Aotearoa. And in fact, in 2024, we had the highest numbers of syphilis cases recorded. So 774 cases last year. And you could see that rolling blue line. There was the peak in 2019 and then the COVID years when there was less access to sexual health services and testing, and then the highest numbers recorded in 2024. We know that syphilis rates, there's disparities around who gets syphilis. If you're a man who has sex with men, so MSM, your rates of syphilis are 86 times higher than men who have sex with women. And there's also higher rates for Māori and Pacific peoples. So there are inequities in who gets syphilis. So we have Doxy-PEP. As I said, it's a novel intervention. It's got the potential to make an impact on the syphilis epidemic. But with any new tool, there's always potential risks as well. So when we think about Doxy-PEP, there's concern about specific side effects. And in fact, in the trials, in one trial, 7% of participants stopped taking Doxy-PEP due to side effects, mostly gastric related. Then there's also the potential impact on the person's microbiome, and we don't know enough about microbiomes. There's the possible selection of antimicrobial resistant non-STI organisms such as Staph aureus. And particularly when we think about MRSA treatments, then it wouldn't be ideal if Staph aureus had increased resistance to doxycycline. And in terms of sexual health, particularly we're interested in Neisseria gonorrhea and increasing resistance to antibiotics for that organism. This is a picture of a penis, and the other thing that can happen is fixed drug eruptions to doxycycline. So recently I had a young man referred to me from his GP who was getting recurrent penile ulcers every time he had sex. And that had occurred the last 3 times he'd had sex, and each time it was getting worse. And he'd had all manner of treatments provided and creams. And then when I was talking to him, I said to him, "You haven't by any chance just started taking Doxy-PEP?" And of course he had, and he was getting a fixed drug eruption every time he had sex because then he took the doxycycline. So it's not going to be suitable for everyone. And if we're thinking about it as a tool at a population level, what we really need is it to be impactful at that group of people with the highest number of sexual contacts, because that's how you're going to get reduction in syphilis. You need to be able to target the people at the heart of the densest sexual networks for it to be an effective tool. And so we've got this new tool, DoxyPEP. Who are we going to give it to? Are we going to give it to all men who have sex with men, anyone with a penis? Fortunately, we've had some people do some mathematical modelling, and they looked at 10 hypothetical DoxyPEP prescribing strategies, really thinking about strategies that would increase the impact on STI reduction, but reduce the burden of having to take antibiotics. And so you can see that little graph there is numbers needed to treat for syphilis. So you can see the biggest bang for your buck is to give DoxyPEP to people who've been diagnosed with syphilis or who have had diagnoses of bacterial STIs within the past 12 months. So that's the strategy we went with, and you can find all the guidelines and prescribing tools on the New Zealand Sexual Health Society website. The yellow note there is the clinical editor's note on the Auckland Regional Health Pathways. So they've put pop-up notes on chlamydia and syphilis sections, amongst others, to just alert people, remind people about DoxyPEP, and provide links to the prescribing tools. So at the beginning of 2024, we had a round-the-country meeting and came to produce an Aotearoa consensus statement. So we were thinking, as a country, what are we going to do in terms of providing DoxyPEP? In terms of the Aotearoa context, we were very clear that it was an intervention primarily to prevent syphilis. And when we were thinking about who we were going to provide that to, the decision was to really target people with a penis. So cisgender men, trans women, people who are having sex with other men, so MSM, and proactively offering DoxyPEP to people who've been diagnosed with syphilis or 2 other bacterial STIs, so chlamydia or gonorrhea, within the past 12 months. Because that is shown to be the most effective way of prescribing DoxyPEP. Now, there might be other scenarios that crop up and should be considered. For example, you might have someone who says, well, I haven't actually been diagnosed with those infections, but I'm just about to go to the Sydney Mardi Gras, and I think I'm going to be at heightened risk of STI acquisition. So, of course, you're going to consider prescribing DoxyPEP for that person. I don't think it should be a rigid rule. Other scenarios you might like to consider are bisexual people, so someone who's having sex with men, who's having sex with men, but also has female partners and is concerned about potential impacts for people with a uterus in terms of chlamydia and syphilis. And then also I think we always have to be mindful of inequities. And we know that Māori and Pacific people have higher rates of syphilis. So thinking about those groups as well. So this is the prescribing tool that's also on the New Zealand Sexual Health website. And it really just breaks down the process of prescribing DoxyPEP and steps people through. So to make it easy, you're either going to have someone who asks about DoxyPEP, or you're going to actively identify this person at being of benefit for DoxyPEP, and you're going to say to them, have you heard about DoxyPEP? I think you should consider this, and this is why. So people with a penis, so men who have sex with other men, transgender women who have sex with men who have sex with men. So for those people, and in addition to that, they need to have either been diagnosed with syphilis or 2 bacterial STIs in the past 12 months. So those are the groups you're going to proactively offer DoxyPEP to. And then there's the other scenarios that we have already discussed. So the next step is you're going to take the medical history and provide STI testing. And it's just a top tip if you're in Auckland, I'm not sure about the whole of the country, but certainly on the electronic requests, the e-orders for Awanui Labs, use the profile tabs at the top of the screen. We've got bundled STI tests there. And if you look under the profile tabs, you can identify the STI testing bundle that's appropriate for your patient. And you just click on that, and it's got all the tests that you need bundled into one package. So that means that you won't forget the blood tests for syphilis and HIV, or the anal swab for men who have sex with men, etc. And then in the usual fashion, you're going to check for allergies and interactions, and then you're going to prescribe the DoxyPEP. Now, so we've talked about it being 200 milligrams, so that's 2 100 milligram tablets, which the patient is going to take within 72 hours of condomless sex. So you need to be a bit savvy about doing that. For example, if someone's having sex on Friday, Saturday, Sunday, then the smart thing to do is actually to wait till Monday morning and take your DoxyPEP then, because that will cover you for the whole weekend's activities. So we want to minimize the amount of antibiotics people end up taking and maximize the benefit. Of course, you want to discuss the potential pros and cons with your patient about taking DoxyPEP and the importance of ongoing STI testing. So we would recommend full STI testing every 3 months while people remain on DoxyPEP. And then when you're prescribing, prescribe up to 72 tablets. And I mean, 72 tablets is just the amount we worked out. Well, if you were taking 2 tablets every 72 hours for a period of 3 months, that would be the maximum number of tablets you should be getting through. But in fact, people may not need that many. So you'd want to talk to your person in front of you about how many tablets they think they might need. And then in terms of follow-up, checking in whether people need repeat prescriptions for the DoxyPEP. And then there are a couple of scenarios it's worthwhile just being aware of. For example, if you do diagnose gonorrhea, certainly at Sexual Health, because of our concerns about antimicrobial resistance, we want a swab and culture, request cultures. But that's not something everyone has to do, but certainly we're doing a lot of surveillance for resistance for gonorrhea, but something to be aware of. If somebody presents and they've recently been in contact of an STI and they've been taking DoxyPEP, that might affect your management. So there's some good advice on the Sexual Health guidelines, the Aotearoa STI guidelines to look at. So for example, if someone came to see you and they had had sex with someone last week who then told them that they've got chlamydia and they've been taking DoxyPEP, well, you might decide with that person that you were just going to wait 2 weeks and then test to see if they had the chlamydia rather than launching into testing and treatment. Really important, syphilis serology, because doxycycline is a treatment for syphilis, but if you take 2 tablets like DoxyPEP, that's not going to treat your syphilis, but it may affect the serology, particularly if you've got someone with a very early infection. So I think really top tip is if you had positive syphilis serology and someone's on DoxyPEP, you want to pick up the phone and talk to a friend. So phone the Sexual Health Registrar or send through a request for advice, because potentially it will affect the syphilis serology. So even if someone is just EIA, the screening test is reactive, then you want to talk to someone about that result. Okay, and this is the other reason why you need to be aware of DoxyPEP is because it's out there in the community. There's lots of people who are aware of DoxyPEP, and as you can see, the little cartoon that's been hosted by Body Positive, it goes along and the character says, "Where can I get it?" And the other person responds, "From your GP." So talk to them about DoxyPEP. So that means in primary care, need to be confident about talking to people about DoxyPEP. Really, and really helpful to bring up that conversation with people, because there's lots of research that shows that there's many men who have sex with men who are not confident to be out to their GP. So need to be proactive in talking to people about tools like DoxyPEP. Okay, so it's a new intervention, and is it working? So it's probably too soon to tell is the answer, but certainly at Sexual Health in Auckland, we've been prescribing DoxyPEP since June last year, and so we did a quick audit of the first 6 months, 172 people, and we just looked at some paired comparisons before and after DoxyPEP for the same people, so paired individual comparisons, and looked at the outcomes. And as you can see, there were significant decreases for syphilis and chlamydia, and less so for gonorrhea, but still statistically significant. There's some big caveats to this data. We haven't had a long enough follow-up period, and we haven't really been able to allow for confounding factors. So we need to go back and look at that data with a longer follow-up period to see what's really happening. But if we look at a population level, so this is ESR, or they've been rebranded now, is it working around the country? So we can see here, these are the rolling counts for syphilis cases throughout the last few years, with the peak in 2019, less over COVID, and then a higher peak in 2024. The dark purple line up the top is for males. So you can see at the top graph for the whole of Aotearoa, there's a slight leveling off in 2024, beginning of 2025. But when you look at the Auckland graph at the bottom, there's, I think, a significant tailing down of the number of men being diagnosed with syphilis in Auckland. I think that's early evidence that DoxyPEP is working. So, I think we should all be prescribing it. And is it working for everyone? When we look at the ethnicity data for Auckland, it's clearly working well for NZ European, but perhaps less so for other ethnicities. So we need to be really mindful of that when we're talking to patients about DoxyPEP. And just to finish up, so back to our case, what else should we be thinking about for Taumata? Well, we now know we're absolutely going to talk to him about DoxyPEP. But remember, he was diagnosed with rectal chlamydia back in January, so we need to be talking about HIV PrEP with our patient. That's really important, particularly thinking about the diagnoses for HIV in New Zealand in 2024. We know that there was 53 MSM diagnosed in New Zealand where their HIV infection was acquired in New Zealand. 8 of those men were NZ European, 16 were Māori MSM. So DoxyPEP is one thing, but HIV PrEP is also a really effective tool, and we need to be advocating for people to use it. And then think about vaccinations, so HPV vaccine and Mpox as well is another really important vaccine. And I think that's probably my time up. Thank you very much.
Just on time, Jeannie. Thank you so much for that talk. I really appreciate it. We do have some questions coming in. If a patient is already taking doxycycline 100 milligrams daily for skin conditions such as acne and is also eligible for the DoxyPEP, would you use an additional dose intermittently when needed, or would you consider that baseline effective?
Yeah, that's a really good question. And I think we probably don't know the answer to that because we've only had these 3 RCTs overseas. But I would say as a pragmatic response, they should take an extra doxycycline tablet as the post-exposure prophylaxis bit. So then they would be having 200 milligrams.
There's a question here around the messaging and the communication. around the social marketing of PrEP versus DoxyPEP, because they both have different contraindications. And what's your thoughts on trying to encourage the communication around these messages without? Yeah, so I guess, sorry, it's a bit of a long question, but I guess um, in terms of encouraging people to use it, are we sort of getting the messaging out there that not everybody can? And yeah.
Yeah, no, I think that's a really good question because we really rely on our NGO partners for messaging, and Burnett Foundation, Aotearoa Positive do a fantastic job of pushing out messaging. So they're constantly advertising on their websites, but also on all their socials, including platforms like Grindr, which is a sexual hookup app. Uh, but, it's not reaching everybody. We can see that from the statistics. What more do we need to do? Um, yeah, I mean, I'm not an expert in health promotion or how to reach people, but, I think it's really important because what we're doing is not working for everyone.
What are the risks of using DoxyPEP for syphilis or chlamydia? Is there any issues with those conditions?
Well, it's Doxy-PEP, it's the post-exposure prophylaxis. So if you have sex, then it prevents you from catching syphilis or chlamydia. It's not a treatment for syphilis or chlamydia. It's like taking the morning after pill after you have sex so that you don't get pregnant. It's exactly the same. You're taking these tablets in order to prevent you catching syphilis or chlamydia.
Yeah, I guess I wonder if the question was more meaning we're keeping an eye on resistance rates in gonorrhea. Are we concerned about resistance to doxycycline for conditions such as chlamydia or syphilis? Yeah,
Yeah, get you now. Sorry.
sorry.
Not in terms of chlamydia. We've never had resistance issues to chlamydia. Syphilis, maybe, but again, we haven't had issues to date, but that's a really good thought as well. Who knows? I mean, syphilis is still sensitive to penicillin. It always has been. So we have good treatments available for syphilis.
Someone's just asking here if they can prescribe both DoxyPEP and HIV PrEP at the same time, and can they be taken together safely?
Yes, absolutely. They're two very different tablets. So HIV PrEP is the pre-exposure, or PEP. You can have HIV PEP as well, which is actually the same tablet as the PrEP, but it's just when you've taken it after the event rather than before the event to prevent acquisition of HIV. But yeah, absolutely. We've got plenty of people who are taking HIV PrEP, plus they take their DoxyPEP when they need to.
Someone's just mentioned here, thank you for the informative presentation. There's information in the rainbow community talking about drug resistance STI versus taking DoxyPEP, sorry. Shall we be worrying about it? So again, it's around that communication, I would say.
Yeah, it's hard to know. I mean, it's theoretical concern, the whole um, you know, possibility of antimicrobial resistance. And it's, obviously something that we're monitoring, but yeah, I mean, it's good to be aware of it, but that's right. This seems to be an effective tool. We shouldn't let it get away in the way of making sure that people feel comfortable taking it.
Someone's just made a comment here about cases going down because are cases going down because people aren't testing? So are we getting a false sense of security, or do you feel like we're actually still getting the same amount of tests, or do you feel like people are encouraged to test? What are your thoughts on that?
That's a really good question because, I mean, data doesn't tell you the why, does it? It just tells you what's happening. I don't think we've got any information to suggest that people are testing less, though. Certainly not what we're seeing on the ground. Um, and, looking at data from Awanui labs that do the bulk of community testing in Auckland, syphilis testing has actually been increasing year on year, not decreasing. So I don't think we've got any information to suggest that. But that is a possibility.
What about for MSM patients who want it but haven't met the guidelines of 2 bacterial infections over the past 12 months, but have regular condomless intercourse?
Yeah. No, I think that's a good question to ask, really. And I don't think we should be too rigid. I mean, when I went to visit the STI, the sexual health clinic in San Francisco, I mean, they were just giving it to everybody. whereas we're being a little bit more trying to be a little bit more responsible in New Zealand. But, if you have somebody that's interested in this tool and motivated and feels at risk and, gives you information to suggest they're at risk, then absolutely, I don't think there's any reason not to prescribe.
There's just a couple of questions that aren't necessarily related to DoxyPEP, so hopefully you don't mind me just quickly asking these for people. But can you comment on a PrEP injection, which my patients are currently inquiring about? So
Yeah.
it's posted here.
We don't have access to injectables in New Zealand. They do in Australia. So cabotegravir is available in Australia. I don't know when we're likely to get that. But, I mean, it has been something that's being used overseas but is not available in New Zealand, and that would be dependent on Pharmac, and who knows what the timeframes are around that. It is something that people are, encouraging Pharmac to consider. Absolutely.
Okay.
Because, it's another tool in the box, really.
Yeah, brilliant. Would you discuss HPV vaccination with all ages of high-risk patients, even if they've likely been exposed to multiple strains of HPV over the course of their lives? So again, not on the Doxy-PEP, but still important as you talked about it.
Yeah, that's a good question too. And we do at Sexual Health. So, it is licensed up to the age of 46, I think. And so we do actively promote HPV vaccine to men who have sex with men up to that age. But I guess when we are, providing it, we had that conversation with people. We say, well, it protects against 9 different strains of the HPV virus. I don't know if you've been exposed to one or none or all of them already. So we don't know if for you as an individual it's going to be effective, but it's certainly not going to do you any harm. And I guess the other thing is that we're providing it free, so there's no cost barrier to people.
Can you advise people where they can let people know where to get the Mpox vaccination from?
Good question. So it depends where you are around Aotearoa, but in Auckland, we run twice weekly vaccination clinics at Auckland Sexual Health Service. Plus, we have the vaccines available in all our clinics. And so you can jump onto our website and book online or phone through and make an appointment to book for the Mpox vaccination. Yeah, and if you contacted Sexual Health too and around the country, they would have advice on where to access the Mpox vaccines in your region.
What's your thoughts on the fact that these treatments, Doxy-PEP, PrEP, are potentially reducing the use of barrier protection?
Personally, I don't. I mean, I just think people don't like using condoms. I mean, we all know that. So, why kind of flag a dead horse in a way? I mean, it's, when you talk to people about the advent of HIV PrEP, it's been liberating for people not to be afraid of acquiring HIV and to be having to be so dependent on barrier methods. So, I think we're moving past those conversations. I mean, sure, we have hundreds of condoms that we hand out every year, probably thousands at Sexual Health. So we certainly promote use and encourage, but we're also very clear that people don't always use them. People don't necessarily like condoms, and that's okay.
Yeah, and I guess that's why we have these tools, right? So it means that people
Yeah.
have options to keep themselves safe and to keep other people safe too.
Yeah, I think it's really important that our messaging is really sex positive.
Yeah.
People have a right to have pleasurable sex that's free from the worry or, the apprehension of having an STI or acquiring HIV. It's really important.
Okay. Well, I just want to say thank you so much again for your time tonight, Jeannie. I really appreciate it. So, our next session tonight is on the new antibiotic guidelines with Dr. Stephen Ritchie. Steve is an academic infectious diseases physician at Te Tokotumai Auckland Hospital and at the University of Auckland. He's the chair of the Te Tokotumai Antimicrobial Stewardship Committee and has spent recent years researching ways to improve antibiotic use in primary and secondary care. Thank you so much for joining us tonight, Steve.
Oh, thanks for the invitation. Yeah, kia ora koutou. So I will share my slides and dive in. So yeah, thank you. This is a project that I think is long overdue for Aotearoa, and we're very proud to be able to, I think, take a small step in the right direction thanks to funding from Te Nifa. Te Nifa recognised the need to develop a national guideline and have supported it very generously. The project has a big team where people passionate about getting antibiotic use as good as we can and make it as appropriate as we can and equitable as we can. I'm lucky to share leadership of the team or co-lead the team with Lily Fraser. Lily's a Māori GP from Taruki Clinic and currently living in Dunedin. And Karen Wright is our other co-lead. Karen's a Māori public health position. The two people, I won't introduce the rest of the team, but the two people who deserve special mention, Sharon Gardner and Eamon Duffy, but they are New Zealand's really lead and principal antibiotic pharmacists, and they've done the bulk of this work, actually. Sharon has pulled together the content of the guidelines with help from the rest of us, and Eamon has done an enormous amount of work in bringing the guidelines to life in digital form. So why do we want to reduce, or why do we want to use antibiotics appropriately? It's all about conservation. We are keen to ensure that antibiotics continue to work for, on my selfish behalf, my children and my grandchildren. I don't have grandchildren yet, but I hope to one day. And you've seen graphs like this before, and they're boring, but they correlate the use of antibiotic in a country on the x-axis versus the degree of antimicrobial resistance on the y-axis. And so New Zealand, we're high users, very high users globally of penicillin and cephalosporin antibiotics, and correspondingly, unfortunately, we have high rates of AMR. So this is in particular showing reduced susceptibility to penicillin amongst Streptococcus pneumoniae, which of course is the second leading cause of bacterial morbidity and mortality in our country, second behind Staphylococcus aureus. But on the right, good news. We're very low users of ciprofloxacin in New Zealand, and we have correspondingly very, very low rates of resistance amongst germs like E. coli. Unfortunately, well, the reason we haven't used a lot of ciprofloxacin is because it's quite a toxic drug, actually. So we haven't lent on that like they have in Italy and Bulgaria, where the drug's not super useful anymore. But this whole thing about countrywide antimicrobial resistance also happens in an individual. So here's a picture from an infographic that we've got available on our website, amongst other infographics that you might find interesting or not. But this is just the results of a meta-analysis that shows that after a course of antibiotic therapy, patients have an increased risk of infection caused by an antimicrobial resistant bacteria in upcoming months. And in fact, this effect lasts out to 12 months. Could be more than 12 months, but these studies generally stopped at about the 12-month mark. So we have this correlation between antibiotic use and the development of resistance affects countries, but it also affects individuals and everything in between. There's research showing it affects households and neighborhoods. People in your neighborhood are using a lot of antibiotics, then you're at risk of a antibiotic resistant infection, even if you yourself haven't personally been taking antibiotics. So what is New Zealand doing about it? Well, unfortunately, not a whole lot. In 2017, we signed on to the World Health Organization Global AMR Resistance Plan or Action Plan. We didn't do much about that. We have a document, but nothing came of that. And Dame Juliet Gerard, who was the Prime Minister's Chief Science Advisor, commissioned the Kotahitanga report. This was led by Matere Harwood, and it's got an amazing suite of recommendations for kind of immediate effect, intermediate term effect, long-term effect, and frankly, we've done none of them really, just quietly. And so this opportunity arose with TANIFA, and we grabbed it with open arms. So two things we're doing as part of this project is developing a national antibiotic guideline, which I'm going to talk about for the rest of the talk. But just along the way, we're also keen to, as proof of concept at least, move towards developing world-class antimicrobial stewardship systems, the type of systems where we can feed useful, constructive information back to prescribers at the front line. Not the kind of crap that tells people off for doing the wrong thing, and that's not effective and doesn't work. But we really want to support good practice and do that in a kind of near real time fashion. And we've got the infrastructure's out there to do it. It's a matter of pulling it together, and we're working on that alongside the development of the guidelines. We have marvellous partners in primary care, National Hōora Coalition, ProCare, Total Healthcare, fantastic groups to work with, and we're hoping to work with more PHOs and more of you on into the future. Okay, the problem, it's not such a big problem, but we just have too many guidelines. It's sort of duplication of effort, really, an unnecessary duplication of effort. But the guidelines themselves that we do have available in New Zealand, and there's something like 30 of them. They vary in quality, they vary in their currency. Some vary, well, they vary a lot in terms of what they have within them. Some are great, some are trusted and used a lot, some aren't used very much at all. But there's a lot of resource going into updating and maintaining these guidelines that, in subtle ways, provide differing advice. So it's also confusing for me as a consumer of guidelines, but my junior doctors I work with in the hospital, and I'm sure you good folks work in the community. Which guideline do you actually use depending on where you are? In Auckland, you can have the situation where if a patient lives on one side of the street and needs hospital care for pyelonephritis, they'll get antibiotic X at one hospital, but patients on the other side of the street will go to a different hospital and get a different antibiotic. It's sort of loopy. So what we've done is we've taken all these antibiotics and harmonised them. So I've taken all these antibiotic guidelines and harmonised them. And our new guidelines are called Te Whata Kura. Te Whata meaning storage place. Here's a photo from the Te Papa website, but it also has the connotation of to bring something into prominence or to highlight something. And Kura means knowledge, but it also has the connotation of chiefliness and something important. So it's quite a fantastic name, I think, of a repository for important knowledge, and we're very grateful to Komini Cassidy for helping us to write the name. We didn't just sit down and write a guideline. That's not the starting point. Our starting point was actually going out into the field and interviewing our prescribers, both in primary care and secondary care. We only interviewed 38 people, and the reason we stopped at that point was because the themes were clear at that point. We were getting the same information back no matter who we spoke to. And the four main themes were these. We needed people want a guideline they can trust. They know it's for them. They want a guideline that's current and up to date. They particularly want something that's quick and efficient to use. I was going to title this slide based on my favorite quote. I don't want the fluff. I just want the answer. And I hear you loud and clear. That's so important. But of course, the guideline has to be helpful. It's got to help us in the situations where we are uncertain in our prescribing and we need some help. The process. So we did this end user research. We've engaged our stakeholders at every step. The content, like I said, we took the existing guidelines and simply pulled them together. We haven't reinvented the wheel, but we've gone out to all the experts in the country, and I mean as many as we could find who wanted to take part. And we've used a Delphi method to get consistency and develop a consensus for what we should be doing and recommending. We've been working with Rush. Rush are our digital partner. They've been great to work with. They're a digital company in Auckland and Wellington. They made the COVID Tracer app for New Zealand and for the United Kingdom. But they've ensured that our what we've developed includes state-of-the-art digital design, i.e. it works really, really efficiently. And I won't read through this table. I'll show you in a second where we can find it if you do want to read it. But the title of this slide is E Waka Eke Noa, kind of meaning that we've got this, but also we're all in this together. We're all paddling the waka together. We're all heading in the right direction. We all want to use antibiotics in an appropriate way. We want to minimize harm to our patients, but also consider harms in a neighborhood, household, and larger community sense in terms of the population harms of antibiotic use. Now, I'm going to switch over, and all things going well, give you a demonstration. So hopefully my screen has changed. This is the test site. So it's not quite as flash as the actual site when it's up and running, but we've got branding that people know and trust. Health New Zealand, we don't have Te Whata Kura branding on yet, but that's in development. There's pages at the top. There's an about page with some information that comes up, and the table about what we're providing and what we expect of our prescribers, or us as prescribers, because of course I'm a consumer and prescriber as well. Um, are there. So we've got sort of extra information around. But look, let's take a quick look at the guideline. Oh, just jump out of that. So when you first encounter the guideline, you'll be asked where you are and what you do. That's simply so that we can collate some usage data, make sure that people are using it, or see who's using it and who isn't, and that helps us with our future marketing. But also, it's particularly important this next few months because the feedback, we're seeking really general feedback and broad feedback from all of you, and knowing where you are helps us to prioritize the feedback. So I'm going to click North Island. We've realized that overseas is a bit dopey, because if you're overseas, you won't realize you're overseas. Also, it's a funny Australasian term, so that'll in the future read outside of New Zealand. I'm going to click that I'm at Te Tumo. That's where I work. And then your role, and we do want all of these different roles to interact with the guideline and use it and look at it. I'm going to just click some buttons at the top. And then we're all set up, and that's stored in my settings. This is cached in your web browser. So if you do this on your work computer, you won't need to do that every time. You just do it once. But if you wanted to change it, you can click the edit button up here in the settings, and that'll change. So then we get to the guidelines. We've divided them into a suite of guidelines more suitable for primary care, a suite of guidelines more suitable for secondary care. It's not that they're suitable, it's just that there's a whole tranche of guidelines in secondary care that frankly aren't useful in primary care. The reverse is not true, of course, but yeah, so we've hidden some. I don't think most of us, myself included, want to know a lot about antibiotic surgical prophylaxis. We'll leave that to anaesthetists and surgeons. And then, of course, we split through child and adult. I'm just going to click on primary. And then we get the familiar indexing system by organ system. And there's absolutely nothing stopping anyone from opening up whatever guidelines they want. None of them are hidden. And just to pick an easy or straightforward topic that I know a bit about, let's go to skin and soft tissue infection, and immediately asks us, well, what is the condition you want? I'm sure you can think of skin and soft tissue conditions that we haven't listed here, but we've got the common ones here. Basically, any guideline out there that had these in them, we've included it. So let's go for cellulitis. And the next thing that pops up are the factors that might influence treatment and might influence dosing. And in previous iterations, you would be asked these things sequentially. Is the BMI greater than 40? Are they MRSA colonized? Do they have penicillin allergy? Sort of a whole bunch of yes/no questions. But we realized that was awful to wade through. And so we spent a bit of money on a good coder to ask all these questions at once. So you can click any combination of these buttons and get the correct advice. I'm just going to click next, just to show you what the landing page looks like. And it brings up 5 days of treatment with flucloxacillin at a dose you might not be familiar with, given 4 times a day, but that's to allow us to take it with food. The research shows that we're trying to take flucloxacillin away from food is a pain in the ass. So let's click some of these buttons just to sort of give more of a demonstration. If, for instance, there are risk factors for failure of straightforward treatment, such as a high BMI or severe venous insufficiency, then we'll recommend boosting the flucloxacillin with probenecid. And the reason for that is that by doing that, we can achieve levels pretty similar to intravenous dosing, actually. But here, interestingly, the number of times a day has changed. We were 4 times a day previously, now we're 3 times a day. Kind of detail, it's impossible to remember, and it just reminds me that it's useful to check these guidelines, even for conditions that we see a lot and know a lot about regularly. Finally, a demonstration of penicillin allergy. So let's give someone a penicillin allergy. And then we're being asked, what is the nature of the penicillin allergy? Is it a delayed drug eruption? Is it a delayed but very serious or potentially life-threatening drug eruption, such as Stevens-Johnson syndrome or DRESS? Or is it a type 1 hypersensitivity in the kind of anaphylaxis realm? And you can click a button, and the advice will hopefully provide suitable advice for you and your patient. Here's some extra advice on the page here. None of that's going to be, well, a lot of that won't, for most conditions, that won't be super important to you. But we realize this guideline will also be consumer facing, patient facing. We don't mind that. So we're trying to provide a bit of extra information. And it may be useful in a consultation, but it may not be. But patients can click on a link and find good information from Healthify about their condition, and when available, about their treatments as well. Because Healthify have lots of information about the various treatments that we would advocate. So we will include, or we intend to include, also a linked using sort of health pathways information that we're trying to sort of distill down to fit on the page in a bullet point about what kind of patients might need, or what criteria might exist for considering admission to hospital. Now, another important thing, giving feedback. So let's say you've made it through to here, you've clicked the penicillin allergy, you've clicked the Stevens-Johnson syndrome history with penicillin, and you've got this advice, but you just don't like it. There's something about it you think is wrong. Then you'd click on the Give Feedback button. And you don't have to enter your email address, but if you do, that helps us get back to you to follow up with the question if we need to clarify anything. But here we can, put in some feedback. We're particularly interested, as I'll explain in a moment, on feedback that seeks to improve the equity of antibiotic use in Aotearoa. And so that's why this button is here, so that we can prioritize feedback or group feedback together. And you click the send button, and it'll get to us. Now that's if you don't like this particular guideline. There are there's several thousand different branch points in the algorithm sitting in behind the guideline, and we think we've got them all right. But man, the testing, we've gone through 2 phases of testing already. We've got another one that's just about complete. I would like to say it's 100% perfect, but it won't be. So we actually want you to go out and break it and find the problems. But please, if you find a problem, don't just sort of turn off your computer and say these guys are idiots. Help us. Join with us. Help us. We're in the same waka together. Give us the information we need to fix it. Another way you can provide feedback. So let's say you're not worried about a specific recommendation or a specific guideline. But you just wanted to say something about the guidelines in general, or what you think of them, then there's a general give feedback button at the top as well. And we appreciate that. Of course, we want constructive feedback. Any feedback's good, but constructive feedback in particular. I've got one more slide, so let me just go back to my PowerPoint. Feedback. So we hope to get this out to you shortly. Maybe the week after next, and we're going to disseminate it through PHOs, the Royal, the College of GPs, etc. We're going to send it to everyone who we think might be interested. So I'm hoping it will find its way to many of you. And like I said, we want feedback on everything, but particularly constructive feedback, and provide evidence when you can. We realize we're humble, normal people. We realize we can't know everything. And so, feedback with evidence is going to be particularly valuable to us. And particularly, again, if you've got suggestions that will help us to improve the equity of care in New Zealand. And part of our project's to learn where our care is inequitable. We're working towards that. Thank you very much. I'll stop sharing and
Brilliant. Thank you so
answer
much.
questions.
Yes, we've got some coming in thick and fast. Will this be in an app format, or will it just be browser-based?
Again, that user experience research we did, we heard loud and clear from primary care that browser-based is the way to go. But hospital doctors prefer apps. They already do. They don't walk around with a computer on them, or they do, the computer in their pocket. But it's designed so well that actually it'll be quite functional. It'll function a bit like an app on your phone. When you first interact with instructions, will be come out with it. There's a little button you can push which enables you to add an icon to your homepage on your iPhone or your Android phone, and that'll access the guideline directly. And on the phone, it's been set up specifically for good mobile use, so it'll run well. It looks good. It's been well designed by Rush, and that's one of the things they're brilliant at is app design. The other reason we didn't go for an app is it's expensive. and costly to maintain. It's much more cost effective to maintain a website.
So you've mentioned health pathways and having similar sort of a format within your guideline. Will you be able to get into this guideline from? Will there be a link basically from health pathways? Because often people will use health pathways. It's very easy to navigate, and there's obviously lots of information on treatment as well. Is that going to happen? Is there going to be a crossover?
Not planned at the moment, but we're happy for health. So we've been meeting with health pathways and working closely with them. Um, At the moment, I'm sure you're all aware, but we currently, health pathways have to run regional variants on an infectious disease pathway to allow for the fact that the antibiotic prescribing advice might be different in different areas, and that's inefficient as well. So hopefully this is a win-win for them as well, in that they'll be able to provide one treatment guideline, or the treatment part of the guideline will be suitable for the whole country. I don't think you'd need to go back and forth too often, though. So the advice in health pathways in time should be a near perfect reflection of what's in our guideline. So yeah, we're working closely, and as health pathways are already updating their guidelines, so that they do that regularly, of course, and the recent ones they've updated in regards to infectious disease, they've communicated with us and said, hey, where have you landed on this decision? And so we're making sure already that we're consistent even before we've launched.
There's quite a few questions here focusing on managing patient expectations, and particularly as the increasing use of telehealth and people are demanding antibiotics. Is there any work going on the side of this to educate the general population about harms of antibiotic use? Is there anything sort of public health focused to support the guidelines in action?
Well, that was part of our user experience and sort of user interface work. So if an antibiotic is not recommended, the page says that. So bronchitis, for example, you click on bronchitis, it says actually antibiotics aren't recommended and has further information. That's not super useful, but if you're in a consultation, you could slant the computer in the direction of the patient and say, oh, good news, you don't need an antibiotic today. Look, we need to do way more work with our whānau population to understand the good things and bad things about antibiotics. In a separate piece of work, we've started to develop some resources. We've tested them with patients. We've tested them in clinical settings. They're available on our website, Antibiotic Conservation Aotearoa, and you're welcome to have a look and use the ones you like. You can direct patients to our website. There's stuff about the 4 common syndromes with URTI: cough, sore throat, earache, and nasal congestion. And they all kind of lead to the same thing, except for the sore throat one, where rheumatic fever prevention is important. But they all lead to the same sort of inflammation. And our focus in our sort of qualitative research that we've performed mainly with Māori and Pacific people, we've learned post-COVID actually that people have really good understanding that viruses, like a virus that causes COVID, don't respond to antibiotics. That knowledge is out there. But what they are uncertain about actually is what illness they have, whether it's viral or bacterial. And so it was sort of an eye-opener for me. I hadn't kind of made that fact that people often struggle with knowing what's a virus and what's a bacteria. But yeah, we need to do more and try and reduce the demands on antibiotics. But hopefully here we have if people are willing to adopt it and use it, a reasonable authoritative guideline that we can use with our patients. We're going to do some qualitative research with population members as well. So just to see what they think of the guideline. Do they understand the technicalities of it? How would they use it? What might they think of you? How would it be useful for them if they're having a consultation? Because it's on a web page that's publicly facing.
There's this increasing pressure on primary care with patients not being able to access appointments easily, having long waits till they do. So when they do get seen, they can often feel like there isn't, like, if I don't get treatment now, am I going to have to wait if it is bacterial, or if it, So I think that's quite a stressful situation that a lot of primary care practitioners are in at the moment.
It's really hard. I mean, the research shows that if an experienced nurse or doctor diagnoses a cold, they're very, very accurate. In fact, way more accurate than a swab up the nose would be, actually. So yeah, it's a challenge. So we've just got to get the messaging out there, but it's hard. Ideally, this would be a central government type thing, but we haven't gone there in New Zealand. They have in other countries like Australia.
Quite a few people are wondering about the about BPAC and what's happening with BPAC, and will this impact BPAC, or is BPAC part of this as well?
BPAC are an important stakeholder with us. The BPAC guideline um, it has basically been incorporated for the most part and updated a little as we've developed this guideline. So yeah, no BPAC, and I haven't shown you also on the guideline, but it links out to the New Zealand formulary, which of course the BPAC people run, and that's a perfect and trusted source of information about drugs that we have no intention of. Well, we love it, and yeah, we link out to it and use it. So no, we're not sort of trying to compete with anyone or outcompete anyone, but hopefully this is a win for all of us.
Is there any room in the, and I guess maybe this is what we're trying to stop, I don't know, what I'd be interested to hear your thoughts. Is there any room for back pocket scripting?
It's something we debate in our group, and there's definitely a role. And so we're writing a guideline in terms of which antibiotic is appropriate and which in the circumstance. But of course, we can't cover the logistics of every single consultation or every nook and cranny in the country. So Leanne Takaru, who's a prescribing pharmacist and a member of our team, she works in the central North Island. She's sort of based in Turangi, but she has patients that extend up the Whanganui River. And she has patients that get on a boat and drive down the river 2 hours to see her, or motor down the river to see her. So, we have to adopt to our own clinical setting. And back pocket prescriptions have been shown to reduce antibiotic use to a degree. But then other research sort of is slightly conflicting in that some research done by sort of psychology type folk have shown that, or social scientists have shown that patients' satisfaction with a consultation is lower when they get a back pocket prescription. They sort of come out sort of confused a little, somewhat, and yeah, so we're not certain. So our response is we're going to have a we would recommend back pocket prescriptions, but we don't, how you utilize the guidelines up to you and up to the prescriber. And we're also going to consult with the academic general practice units in the country just to get their take on back pocket prescriptions, so that we can promote the advice that's being taught.
And so would that be factored into the you've gone through the guideline, don't need antibiotics, but would there be a little like asterisk saying you may consider, or would that just not be, you'd have to, that you wouldn't put that as part of your guidelines?
We could do and it's just going to come down to the feedback. If people want that, then we'll do it. At the moment, what we're contemplating is the kind of top of the guideline where I showed you the about things and scrolled through it very quickly. We might have a page there or a link there to some information about back pocket prescriptions that comes from the academic GP units in the country. Yeah.
There's a couple of people asking about the antibiotic use in animals and farming. Has that led to an increased antimicrobial resistance as well? What's your thoughts on?
To a small degree, but almost all of the antimicrobial resistance we face is from use in human health. Our antibiotic use is going down, but it's going down very slowly, sort of 0.5% a year, maybe a touch more. It went super low. Our antibiotic prescribing dropped enormously during lockdowns with absolutely no detriment that we could detect. So we think we can safely reduce, but it's got to be equitable. Antimicrobial stewardship is all great, provided we don't do harms to the very groups we least want to harm. So, and that's one thing we're doing in this project is looking at the equity of antibiotic use and trying to make sure that our AMS drives and things that we want to do are entirely equitable. So, yeah, I lost my train of thought. But the question going, I had one other thing to say about it, but
It's just around antibiotic use in animals and farming.
Animals, yeah. Okay, so we were very high users in animal health in New Zealand, but a few years ago, maybe a decade or so ago, perhaps less, there was a commitment to only use antibiotics for sick animals in New Zealand. And in doing so, our veterinary colleagues have dropped their use enormously. So they're making reductions of 10, 20+% per annum. Their antibiotic use has plummeted. So really, they've both left us behind.
Interesting. Well, that's all we have time for tonight, Steve. I really appreciate it, and I'm really looking forward to when these guidelines are launched, so we can have a go with them and see them in
Yeah,
practice.
coming to a computer near you soon. Thank you very much for your time, and thanks for listening.
Right. Thank you. So we are on to our third session of the evening, standing segments with Dr Sue Tutty. She works as a primary care advisor in Tamaki Makaurau, and is joined us tonight. I really appreciate you being here, Sue.
Thank you, Kate. Good. Well, moving into our last session now on the clinical updates, and it's quite a full agenda tonight, but I wanted to start with the cellulitis pathway. So we've had a great introduction to that from Steve already tonight, and this is a national pathway, and it's made use of the antibiotic guidelines that we've just been shown. It's to be rolled out from about the 14th of August, but it will vary across the regions of New Zealand. But the biggest change that it has in it is that there is now no place for IV antibiotics in the community. And there will be a standardised funding model that gets implemented across New Zealand as well that goes along with this pathway. And you can see this is some of the information that I've taken off the draft pathway yet. The pathway will come out when the rest of the when this pathway goes live in August. And I've given an example for moderate to severe infection, and you will see that it talks about uncomplicated cellulitis with no allergies to penicillin, and mention some of the specific things that we might need to worry about too, which is animal bites or environmental contamination, and of course the staph resistance MRSAs. And I've given one example of the medication to use, which is exactly what Steve just told us about, the flucloxacillin 1 gram 4 times a day plus probenecid, because this is for moderate to severe infections. And you can see it also gives some information on what to do with renal impairment. So just a few more comments about this pathway. It talks about wound swabs and the fact that we really shouldn't do them unless there was a reason to do them. And that is if the cellulitis is not improving in 48 hours, if you're worried about an MRSA or an unusual organism. And that goes back to the ones I mentioned before, bites or wounds sustained in water or other environmental contaminants. That blood tests are only needed if the cause is not clear, and blood cultures are probably not necessary in primary care. Just as a practice point, we used to remember drawing all the lines around the redness, but they're saying erythema resolution is actually a poor marker of response. And so it takes some time before that erythema will start to clear, and not to use it to determine your ongoing management. And just to remember to remind you again about the special circumstances. So they're the necrotizing skin infections, people with diabetes, with ulcers, dog bites or bites as we've talked about, sepsis, and when people are significantly unwell or have comorbidities, specific sites like cross joints or in the hands or around the eye, and to consider perineal or lower abdominal cellulitis, and other medical conditions that might affect what's happening, such as having nodal dissections in the area. And this is a pathway that's looking at the funding. Now, this is what's been recommended on a national basis. It may well be slightly different when it's adopted through your regions, but it talks about the reactive and the proactive follow-up. And in the box on the bottom right of your screen, you will see the reasons for proactive follow-up. And they're the sort of things that Steve showed us on their antibiotic guidelines, the obesity, the venous insufficiency or the peripheral vascular disease, And it also includes an equity factor there with the community service card holders as to who would qualify for reactive or proactive follow-up. Reactive is when the person's asked to come back if they're not getting better. Proactive is when you do some follow-up yourself, such as a phone call within 72 hours, and then maybe follow-up in person if that's required. And there's been some funding put alongside this, which will be national funding. And it depends on whether it's reactive or proactive. So that's a bit about the cellulitis pathway. Another new pathway that's rolling out is sending out of area referrals. And this is particularly for clinicians that are working on the boundaries of districts or regions where it becomes very hard sometimes to know how to refer the patient. And it gives access to all the health pathways for that region so that you can check what their different referral criteria are and send the appropriate referral then to the appropriate to the appropriate area of specialty. It also gives us the opportunity to see what's happening in all the different pathways around New Zealand, so you can compare the way things are managed in different places. We're starting to have more national pathways coming out. They still will be localised in terms of referrals and things, but like the cellulitis pathway, the funding mechanism behind them should be consistent, and a lot of the advice should be consistent. And this just shows you by region the different ways that the e-referrals are done, whether it's done as a health link, a BPAC referral, or an ERMS. So they're the three major ways. Now, if you are on a border, you may want to contact either of one of these three mechanisms, and so that you're able to use them in your own practice. I understand that anyone who uses ERMS can use ERMS in any area that links with ERMS, which is shown on this previous page. There's a few things to just be careful of, though, that if you're using a referral through a different mechanism than the district's electronic referral system, you won't get the same reminders from them. So you might not realize, it might not tell you automatically if your referral's been accepted or graded or when an appointment has been arranged for your patient. So just consider putting a task to yourself in your practice management system. The pathway will show you how to do all these referrals by specialty if you can't access the ERMS or HealthLink or BPAC. Moving on, I just wanted to mention scabies management because it's become a bit more topical, particularly in the northern region where we're seeing quite a lot of scabies occurring now. And just to take your attention to the editor's note that's been put on the pathway, showing that we can have this special authority access to ivermectin now, and that is a second-line treatment when topical permethrin treatment fails. So just to be aware of that. And a quick note about Hyprex, which is used for the prophylaxis of urine infections. But when you are treating an infection, when you need to use antibiotics, then it's important that you do stop the Hyprex, because there is a real risk if it's taken concurrently with sulfonamides, it can cause crystalluria. So just that message about Hyprex, it's useful to suppress bacteria, but only when the infection's treated. It doesn't work with structural urinary tract abnormalities, and its effectiveness does depend on the acidity of the urine and the number of bacteria present, things like that. So you can't take antacids while you're taking Hyprex. Few updates from Pharmac. Soframycin is not available during July and August, so you'll need to write a prescription for a different treatment. It's not able to be just transferred over. Methylphenidate we've talked about many times before, and it's I haven't listed all the doses and brands that are available at the moment. It's best to just check what's available at the time you need to use it with your local pharmacy, because even if it's available with the supplier, it doesn't always mean that the pharmacy's got access to it. And we now have nicotine lozenges and hydrocortisone powder is back in supply. Continuous glucose meters, the Libra Freestyle 2 is being discontinued and replaced by the Freestyle Libra 2 Plus, which is just a better device all round. It lasts longer and it works better, but it does need a new special authority. So if you're seeing someone who's asking for their Libra Freestyle 2, please change them over to the 2 Plus so that everybody doesn't need that when we run out of the older version. Those of you that were at the GP College conference at the weekend will have heard Sam saying about 1 puff of salbutamol is equivalent to driving a Toyota Corolla for 290 kilometres. And the suggestion that we shouldn't be using a lot of aerosols, and aerosol salbutamol particularly. Pharmac have now changed the special authorities and the prescribing for Symbicort so that we can now give a 3-month supply, and it's available on a practitioner supply order if you want to use that for your patient who might be needing some treatment in your surgery. And this supports the ongoing implementation of the New Zealand asthma guidelines. And it just gives you another option to use in your practice. And from the 1st of August, we will be able to get Shadell's, Shadesses and Marinas on MPSO, and the number of Shadell's that you can get has also increased. So instead of being able to get 3 packets at a time, you can now get 20 packets. It says 40 implants, but there's 2 implants per device for Shadell's. And lastly, just my section on looking forward. There's been a lot of talk about the community referred radiology that's coming. And I just wanted to draw this to your attention because I think our next webinar, which will be in September, the last Tuesday night in September, we will be talking about this community referred radiology. The why is to access, so we can access timely and effective radiology to provide better care for our patients with reduced waiting times, improved outcomes, and some national consistency so we can identify any equity gaps there might be. And you can see on the right of the screen that this is going to cover quite a lot of radiology. It's coming in the next few months, but it will take time for it to embed, and it will be perhaps rolled out slightly differently across the regions, but good to be aware that this is coming. Just a few updates. The Health New Zealand board started on the 24th of July, so it's just started last week. It's I've listed the people that are in there if anyone wants to know who's on the board. And you will have heard about the minister's speech at the conference on the weekend, and just talking very briefly about capitation. You know, it's the government funding that we get in general practice that was introduced in 2002 and hasn't really been updated since then. The reweighting that was mentioned will begin from 1st of July next year, and it will be reviewed regularly after that. And you will see the note that most practices will get an increase in funding from this. So capitation used to be related to a person's age and sex, and now they have included rurality, deprivation, and multi-morbidity. And they've chosen these additional factors because they know that they do affect patients' health outcomes and the level of care that they will need, so that there will be that practices with higher needs population of enrolled patients will receive more funding to care for them. Changes to the funding for general practice education so that people in their second, third and third year of GPAP and this year will get help with their funding for their education and for their examinations, and they will continue to fund GPAP year 2 and 3 trainees for each year. And this is just putting the same investment into general practice funding as they do for medical specialist funding. There will be a new target in primary care with 80% of more patients. That 80% of our patients will get an appointment with their GP within 1 week. And again, this is expected to start from July next year to provide better timely access to care, and it aligns with the mental health targets. And there will be a lot of work before this is fully rolled out so that we can work out how best to design this and to make sure that there are no unintended consequences. And lastly, the Minister will be setting up a primary care advisory group to advise him on what is happening in primary care. So there will be that direct voice into the Minister's office. Any questions?
Yeah, thank you so much for that, Sue. Someone's asked here about the what are patients suggested to look out for improvement if the resolution of erythema is not a reliable sign with cellulitis, and the only improvement is in tenderness.
Probably the main thing to watch out for is the patient's wellness, really. So it's those markers of pulse and blood pressure and temperature, and just to see that they are recovering rather than getting worse.
Yeah. Any suggestions for the patient who says dry powder inhalers don't work for me?
There is Veneer is still available, and salbutamol is still available. It's just to consider the environment. And if the dry powder inhalers do work, then that is more environmentally friendly.
Radiologists are already quite overwhelmed. Getting CT reports can take 3 weeks to be reported. Do you have any thoughts on how they're going to cope with more imaging with the new, or is this going to help streamline things with the new radiology guidelines? Or should we just wait and see for the September?
The hope is that the new guidelines will streamline it all, and that because we've got very specific guidelines, but we'll hear more about it, as you say, in September.
Brilliant. In terms of capitation, will ethnicity still be factored in?
Ethnicity was not something that the Minister mentioned, and it was something that he was questioned on after his speech.
Is there funding for nurse practitioners available too in regards to
capitation? I would think so, because this is patient enrolled funding. It's government funding for your enrolled patients. So.
And will there be new capitation money next July, or is redistribution of the pipe going to practices with higher needs?
I think that it is going to be related to the increased capitation that has already been talked about, but I think that some of that was not particularly clear from the Minister's speech.
Well, thank you so much, Sue. I really appreciate your clinical update segment, as always. We will finish up here tonight. Thank you so much again to all of our speakers for taking the time to present this evening, and to Te Whatu Ora for supporting the delivery of this content. Thank you so much for everyone for joining us tonight. Have a lovely night, everyone. Ka kite.